towards the end of this seminar, we are joined by the HSE National Consent Advisory Group. And we were responsible, I guess, for chairing the committee which developed the policy on advanced care planning and DNARs in light of COVID-19. These 3 seminars have been about exploring that policy in more depth. In many respects, the policy doesn't change anything from the previous policy, which the position in respect of advanced care planning and DNARs, but we really sought, following consultation, to really bed down this idea of advanced care planning. And so in our discussions, we've dedicated 2 sessions to thinking further about advanced care planning, last week and this week. And this week, we're focusing particularly on supporting people to make advanced care decisions. And one of the things, and our speakers are eminently well qualified to speak to this, one of the things which we think is really, really important is that everyone can advance care plan. The fact somebody has an intellectual disability, the fact that somebody has dementia is not of itself a barrier to advanced care planning. That's very important. And our speakers today will be talking to that and to the potential for working with people for advanced care planning. I'm going to very briefly take you through some technical issues before we turn over to our main speaker of the day. I'll introduce her in a moment. So our technical issues are as follows. Many of you have been on this before, but just in case you haven't, and you are not familiar with WebEx, if you want to change your video screen, you can go to the top of your screen, and that gives you a number of options. You can watch this in grid view, which might be nice if you're watching the panelists during the panel discussion, or you can watch it with single speaker view, whichever works for you best. If you have issues with sound or internet connectivity, you can dial in, and the dial-in details will be in the chat box. Chat box is open, and if you have any issues in terms of connectivity or indeed anything else, please use the chat box. When you're using the chat box, just make sure that your comments go to all panelists, so that, all attendees, so that everybody can see what's coming in. We will try to address your questions as they come in, not as they come in, but towards the end of the seminar. We'll have a bit at the end where we'll try to work through them. We'll do our best to get to everything, but some things we won't get to on today because we're very conscious of time. But anything we don't get to, we will try to address in facts or in individual responses. There are CPD points available both from the RCPI and for the NMBI, and you'll be getting a confirmation of attendance in the next few days. Webinars being recorded, and you can watch it or indeed pass the link on to any of your friends, and that's available at www.assisteddecisionmaking.ie, as indeed all the other previous webinars were recorded. Final point I think to make, which is if you'd like a sector or professional specific discussion, we would be very happy, or I should say the office will be very happy to provide that. So if you contact Jacqueline or Marie Teig, Jacqueline Grogan or Marie Teig, and we will put all those details and everything there in the chat box. So it is my very great pleasure to introduce Dr. Fiona Morrissey. Dr. Morrissey is a graduate of NUIG. She's also affiliated with the Disability Centre at NUIG. She's immensely experienced in training she's immensely experienced in researching and training around advanced care planning. She spent some time in Virginia developing her work in this regard, and she sees enormous potential for advanced planning for everyone. So she's got a great deal of experience in doing this, and it's experience which she uses to very good effect in her work with the World Health Organization. She travels around the world providing training in accordance with World Health Organization policies and practices around disability and advanced care planning. So it's my very great pleasure to introduce Fiona Morrissey. Thank you, Fiona.
Thank you, Mary, for the introduction there today, and I'm delighted to be here because I think healthcare workers are uniquely placed to support people to make decisions around their future treatment and care and to advance care plan. It's really, really important, as you said, that everybody is allowed to do that, regardless if they've got, an issue around an intellectual disability or dementia, that we try and support people as much as possible to make their own decisions around their treatment and care. So just for a minute to start with, I just want you to imagine if someone else was making decisions for you, that they could decide to take you away, lock you up, not listen to you, and to give you medication and block you from doing your work and living your life the way your mind and body are now. And would you want that to happen to you? Would you feel that you'd lost your dignity, and would you want it back? And that's something I suppose we all need to think about when we're making decisions on behalf of other people. How would we feel if people were making decisions on behalf of us? And that's a quotation from the drafting of the UN Convention on the Rights of Persons with Disabilities, which was drafted in 2006 and which Ireland has now ratified. So we've signed up to this new supported decision-making approach, and it will be included in our new capacity legislation as well. So any of us can be in this position at any time during our lives, and at those times we're very vulnerable to not having, when we don't have capacity to make decisions, and that might be due to aging, illness, whether it's physical or mental. And it's at those times we're most vulnerable to being abused. So we need to be, be conscious that any of us can be in this position at any time during our lives. We all age, hopefully, as we get older, we're lucky enough to live long enough. We get some illness, we're in a road traffic accident. So any of us at any time can use capacity to make, treatment decisions for ourselves. And if you were in an accident or you had an illness and you couldn't speak for yourself, who would you like to speak for you? Would people know what you wanted? Would they know what care and treatment you'd like? Would they know what you wouldn't want? So if we don't plan, someone will make those decisions for us. We can't speak for ourselves. And who will make that decision? It might be somebody who doesn't know us, and that decision may not be in accordance with our wishes. So you need to think about yourselves first, even before you start to support other people. Who would you trust to communicate your wishes in relation to your healthcare treatment? So it should be someone you trust and who's capable of making decisions on your behalf. And that person may not be your spouse. Just to say that as well, there's some research around that as well. So when you're supporting people to make decisions around their future treatment and care, it's really, really important work because it enables them to continue to have a voice in their own care. And it also prevents conflicts at later stage, which can arise when the person's wishes are unknown. And we have a number of cases in the courts at the moment in Ireland around this, where people's wishes are not known and their family just want to continue with artificial hydration and nutrition, and the hospital wants it to continue. And the family are saying, my daughter wouldn't want to live in these circumstances. So if that person had an advanced care plan, it would avoid that conflict because we would know what their wishes would be in the situation. So it really allows future treatment to be provided in accordance with the person's wishes. And it's respect for the voice of the person, which is better for all of us. I just want to clarify, first of all, the difference between substitute decision-making and supported decision-making. Substitute decision-making is probably what we've done a lot, and we do with people around us sometimes all the time. We need to be conscious of this in our practice, that when we're making decisions for others, that it can be damaging for them. So substitute decision-making is when decisions, treatment or care decisions, are made for another person by others in what is sometimes deemed to be in their best interest. It's often well-intentioned with the aim of protecting the person. So we don't mean to do any harm when we do this, but sometimes it doesn't actually help the person. So that may be formal and informal. It might be by family members, it can be by healthcare workers, or it can be formal in that somebody is appointed by the court under wardship to make decisions for a person. And just to say that next of kin don't have legal authority to make decisions for the person, but in practice they're often consulted. So it's really important to understand the negative effect of not allowing someone the opportunity to make treatment or care decisions. And we had a case recently in the UK, where a care decision, treatment decision was made for someone, and then the family were very upset afterwards because she wasn't resuscitated, and she hadn't been asked about that decision. So it can be profoundly upsetting for the family and for the person. So consistently taking away people's opportunity to make even small decisions can be damaging and disempowering. And these decisions are what make up our identity and our life values. So by not supporting people to make their own decisions, we're denying them the right to make healthcare choices and to live as they wish. And that can become a vicious cycle for people. if you're never given the opportunity to make decisions, you never learn. It's like at some stage you have to learn how to cross the road. So decision making is like a muscle. You need to exercise it in order to strengthen it. Hopefully not as much as this guy here, but anyway. So people who are not used to making decisions for themselves may quickly defer to others and need encouragement to make their own decisions. And that's sometimes where healthcare workers can come in and encourage and support the person to make their own decision. And the more you do that, the better the person gets at it, regardless of their capacity or disability. When people are not given that opportunity to make treatment or care decisions, they have very little control of their lives. And supported decision making is used when someone finds it challenging to make a decision. And it's something we all do to some extent in all our lives. I'm sure we all remember, helping someone to make a decision or being helped by someone to make an important decision in their lives. We tend to ask people around us when we have to do that. So it's a very natural process we all engage in. We all need support to make different decisions at different times in different areas of our lives. So it depends on the decision and the timing. And we might need more support to make some decisions than others. And we often turn to people we trust to help us to do that, or maybe to healthcare workers or professionals. Our supporter never makes decisions on our behalf or instead of us. And some people, like people with cognitive disabilities, might need more support than other people to make decisions. So just be conscious that they might need more support than we do. But we all do it to some extent. So in supported decision making, the person is at the centre of all decisions. So it's moving away from best interests towards putting the will and preferences of the person at the centre. And our new Assisted Decision Making Act requires that. The focus is on supports the person needs to make the treatment care decision rather than deficits in capacity. So this supported decision-making approach can improve our everyday practices in the healthcare services and save time in the longer term. So why is it important to make decisions or to support a person to make decisions about future care and treatment? Other than what I've already said, when a person takes a lead in treatment and care decisions, it's more likely to meet their needs and they have better healthcare outcomes. It also provides a sense of control in situations where people often feel they have no control. And I did a study here in Ireland, and 61% of people in mental health services felt they had no control over their future treatment. It allows a person to be treated in accordance with their wishes and values, and it also decreases decision-making burden on the family members and also on healthcare workers. And this causes less distress and conflict for everybody. And we see this, in these cases that are going through the courts. If advanced healthcare planning was in place, we wouldn't have these cases in the courts at the moment. So it's really, really important. And the research shows that 45 to 70% of people are only able to make decisions when they're needed, coming towards the end of life. So it also enhances the therapeutic relationship and empowers people to make decisions. So we said earlier, about the muscle. Your decision-making skills get better as you practice them. It also gives people an increased sense of choice and respect and dignity and autonomy. It also provides information that we need to make decisions or to help make decisions in accordance with the person's wishes and provides clarity. It also reduces the need for coercion. So we now don't, if we know what the person's wishes are, it means it's less likely that we have to treat them without their consent. And treating people without their consent can cause additional trauma for the person. So it's not just about dying or end of life, it's about living well. And the research also shows where, people do engage in advanced care planning, it improves their quality of life and care, where they have life-limiting diseases, and it reduces the need for someone wanted treatments or invasive treatments they may not want. And it's also about enhancing recovery, particularly in mental health, where people may have had previous experience of treatment or in maternity care. So it's very much about, we tend to associate with end of life and dying. It's very much about living well as well and recovery. And then also when we come towards our end of life, about dying well. So you're more likely to die at home than in a hospital or institution if you do engage or support people with advanced care plan. And 68% of deaths in Ireland are actually in hospitals or institutions. So it's really about allowing the person to have a voice in their treatment of care or through a trusted person they've appointed. So it's a basic human right to allow people to make their own healthcare choices. And then when we are supporting people, I suppose I said at the beginning, healthcare workers are uniquely really placed to help people and to support people make future care and treatment decisions. And I know many healthcare workers are already doing this in practice. So, consciously using a supported decision-making approach is really, really important. So the supports may be informal or they may be formal. So we don't have to wait in the legislation to start doing this. It may be very simple, by communicating information the way the person understands, consistently asking a person what they want, communicating, listening and engaging with them. So it's very, very simple, but it's about consciously implementing it into your practice. And the level of support a person needs in relation to future treatment and care depends on the person and the context. So support should be always based on the needs of the individual and should never be forced on the person. So how can healthcare workers support a person to think about their future treatment and care? Well, the research shows, both internationally and nationally, that people want and need support from people around them and from healthcare workers and independent people to advance care plan. And in Ireland, when I did the research here, it showed 85% of people in mental health services wanted support to meet the advance healthcare directive. So completion rates increased dramatically internationally, where the person had support to make an advanced care plan. And in fact, in a healthcare system for Respecting Choices, the Respecting Choices program in a healthcare system in Wisconsin, you have participation rates of up to 90%. So support is really critical. Now, that support does not have to be from a healthcare worker, but you can help with the process and you're uniquely placed to do that. It's good practice to start that conversation with people, to engage with them on it, and it prevents problems later. So I would suggest that you would initiate the conversation with the person as part of an overall conversation on their values and give them information they need in a format they understand. It's also about giving the person time to weigh up the information, to make the decision, and some people might need more time than others. And the research that was done in the States shows it can take 2 to 3 sessions of 90 minutes for a person to make an advanced healthcare directive, which is a legally binding document. So people need time to think about these things. And, also to refer people for independent support if needed, like advocacy, speech and language therapists. So it's allowing the person to talk to trusted people close to them. And it's not just a one-off process, it's a constant engagement with the person's wishes on an ongoing basis. So the steps really, I suppose, to support people to make these decisions is to start that conversation with everyone. And to do that, you need to start with yourself. Because as healthcare workers, we need to have our own advanced healthcare plan in place before we start supporting other people. And we can understand then what it entails and what it's about. So focus on the supports the person needs to make the decision, not the deficits. It's important not to make blanket assumptions about the person's capacity or age. And the timing is critical. Ideally, these decisions should be made as early as possible, not in emergency situations where the person or family are too distressed. You might need to provide information in a visual format or simplified language, and get the person to think about what they might want or who they would trust, and give them the time to do that and to talk to people around them. I would suggest as well to these people that think ahead forward. I know Deirdre will be probably talking about that here today. And if after taking all possible steps to support the person, it's still not clear what their wishes might be in the situation, try to determine what the person's decision might be in the circumstances. And you can do that by talking to people close to them about their values, any previously expressed wishes they might have in relation to their treatment and care. It's important to document these conversations and the supports given to the person so there's no confusion around that. And I have a checklist here which might be useful for people. When you're actually in practice, you can just use this checklist to, just determine whether you're actually engaging in supported decision making. It's quite simple. Again, it's about providing information in a way the person understands. It's about communicating with them in an appropriate way to them, making them feel at ease. So I'm sure we can make this available to people afterwards. I know it will be up on the website as well. So what do healthcare workers need to consider? Well, there is a fine line between supporting and influencing, and healthcare workers need to be conscious that you are in a position of power over the person. You have to try to avoid influencing them as well as giving them, the information they need and supporting them as much as possible. So give them the information in a non-biased manner in a form that they understand. ensure that they understand the information, and give them time to consider it and ask questions. And ensure the decision is based on the person's wishes rather than what you think is in their best interest or what their family wants. And remember, what you want, what I want, what my family wants, and what my healthcare worker wants might be very different. So you need to try and resolve conflicts there and alleviate fears, any fears family might have as well, and support the person as far as possible to make their own treatment and care decision. And to continue to support them, even if they make a decision you disagree with. And that's the difficult part. So what should the person, so if we're all going to make our own advanced healthcare plans, what should we consider? Well, discuss it first of all with people around you. Who would you trust to communicate your treatment and care preferences? And to remember that a significant percentage of people do not have someone they trust. In fact, in the research here in Ireland, up to 30% of people in the mental health services did not have somebody they trusted to make and communicate their wishes in regard to future healthcare treatment. You need to be conscious of that as well, that some people don't have anybody. Discuss the person's values. Talk to them about, think about yourself, what preferences you might have in relation to treatment you do or do not want. It may be based on past experience of side effects. And then what your wishes might be in relation to life-sustaining treatment, CPR, artificial nutrition, or hydration, if there's no prospect for your recovery, and quality of life issues. You may also want to include things like place of care preferences, wishes on where you would like to be cared for. Would you like to be cared for at home, in hospital, or in a hospice? And other life choices. A lot of people, up to 20% of people include who they like to look after their children if they're in hospital, pets, that kind of thing, who looks after their home. So these are kind of examples here of, preferences that people will put into an advanced plan. So just very simply, the first thing is to appoint somebody you trust to communicate your wishes if you're unable to do so yourself, and to think about who you would trust to do that if you have somebody. If you don't have somebody, to think about what treatment, care and support you would like or wouldn't like. And it might be simple things like you're allergic to penicillin. And this particular person was, a mental health service user, and she found that a particular medication worked well for her in the past, but she didn't want to be treated with another medication because it made her very drowsy. And she also would prefer to be treated at home if possible. And then also, wishes or preferences in relation to life-sustaining treatment. So it's really, really useful to have these wishes written down, because there's no other way of people knowing what your wishes are unless you've actually told somebody or written them down somewhere. And then we can try and respect them as far as possible. And that's better for everybody. And I would recommend, and I know Deirdre will probably talk to you about this as well, is to have a look at the Think Ahead forum, because it provides a very useful template for you to outline your treatment and care preferences and what you might like or what you might not like in relation to your future care. And also for healthcare workers to point people to the forum, or to initiate that conversation and to have that engagement with the person as part of the overall conversation on the future healthcare treatment. And of course, that applies to everybody, not just because you're a particular age or you have a health condition. You should all be doing this. So we have some examples of supported decision-making initiatives in Ireland, which might be useful to look at. There's a project there that they had in Clare for people with intellectual disabilities, where they had circles of support around the person to support them to make their own decisions. And again, the decision was always based on the wishes of the person. And there was also a project there that was done across Ireland, in Cork, and Mayo, and Tip, and Dublin, around supporting people with dementia to make decisions, and some international ones as well. So I hear Marie Spoon, so I think that's me done. So thank you very much.
Thank you very much, Fiona, and that was exquisitely timed. You beat Marie Spoon, and that is an achievement indeed, which you can be very proud of. Thank you very much. That was a really thought-provoking, but also very practical and grounded presentation. It leads beautifully on to our panel discussion, and we may be back to you, Fiona, as we have questions coming in later, but I think a lot of the points which you made we're likely to see taken up and expanded further in our panel discussion. So I'd ask our panelists if they would, and Fiona, if you wouldn't mind to take down your slides now, and then if our panelists would please put on your cameras so everybody can see you, and you can maybe give a little wave as I introduce you, please. So we're very fortunate today in our panelists. Their work works beautifully with the points which Fiona has just been making. So we have three panelists. Our first, and we'll be addressing them and talking to them in this order. Our first panelist is Deirdre Shanaher, and Deirdre is currently working with the Irish Hospice Foundation as their National Development Manager in Palliative and End-of-Life Care. And any of you who were with us last week and again today, you'll have noted from Fiona the enormously valuable resource which the Irish Hospice Foundation has provided in the Think Ahead programme and plan. Deirdre has particular expertise in end-of-life care. She has served on the board of Care Alliance Ireland since 2014. She chairs the research subcommittee of that board. And in the Irish Hospice Foundation, her work centres on advanced care planning, the palliative care for all and primary palliative care programmes. She's been involved and has represented the Irish Hospice Foundation on the HSE National Advanced Healthcare Directives subgroup. And she has, in many ways, unparalleled experience in advanced care planning around end-of-life decisions. So we're really, really grateful to have her with us today. The second person that we will then turn to is Judy. Judy Ryan is the Director of the Nursing and Midwifery Planning and Development Unit for the South East. And her work there involves strategically supporting the professional development of nursing and midwifery. But the reason Judy is with us particularly today is because she is a registered nurse in intellectual disability and has had experience both in the UK and in Ireland in this regard, which again is wonderful to have that external experience. But she has a particular interest in self-advocacy and the needs of people with intellectual disabilities and their capacity to support themselves. She's been involved in a pilot programme to appreciate how people with intellectual disabilities can be supported to engage with the potential of the Assisted Decision-Making Capacity Act. And she's a member of the Guidance and Documentation Working Group for the HSE around that Act. And then our final panelist is someone who at this stage probably needs fairly limited introduction, and that's Sean O'Keefe. Sean, as you know, as many of you know, he's a consultant geriatrician and physician in NUIG and University Hospital Galway. He has a great deal of experience, I should say, and is involved in an enormous amount of public service around delivering end-of-life healthcare and decision-making supports. He has a particular interest in ethical issues around older people. He serves in very, very many functions, and they include being the joint chair of the HSE National Consent Advisory Group, as well as his involvement in the Assisted Decision-Making Capacity Act Steering Group and the Ministerial Working Group. I could go on for a very long time, but just take it from me, Sean has been involved in an awful lot of policy development. So we're thrilled to have you all here. I didn't give you a chance to wave, and my apologies. So Deirdre has bookshelves behind her. I think your names are up there, so I don't need to describe who's who. So Deirdre, I'm going to start with you, if I may, please. And we've got some questions. We're sending some questions to you which are particularly relevant to your particular expertise. So Deirdre, from your expertise, can you take us through the barriers and the enablers which promote advanced care planning? Both the barriers and the enablers, whichever you want to start with.
Yeah, can everyone hear me okay?
Perfect now, thank you.
Okay, I'll leave this up here. So I said I'd start with the barriers and end on a little bit of a more positive note by talking about the enablers at the end. So I think within healthcare, probably one of the biggest barriers is about the ownership of having conversations with people. Everyone thinks that it's somebody else's job, and as it turns out then it ends up being nobody's job, and all of these conversations don't end up happening. I think probably one of the biggest things that happens is that there's a fear of upsetting people. And what we're forgetting within healthcare is that a lot of people who we're engaging with have already been jolted by a diagnosis and they're already upset. So we're not really going to upset them a whole lot more than that. And then I suppose if you look at any research around palliative care or having conversations with people, there's this whole thing about diminishing hope, and that whole kind of argument that goes on about keeping people's hope and killing it. And by having these conversations, there's a fear that it'll just diminish everybody's hope in terms of their prospects for planning ahead. And then I think probably one of the bigger things is the personal nature of death. It's a very personal thing. Everybody's death is an individual experience, and everybody's experiences with death is really individual as well. So it's a really personal thing. And for some people, it's too personal and they don't want to have those conversations. But on a more positive note, some of the enablers that are there for advanced care planning is that we're all human beings. And regardless of any titles that we have as doctors, nurses, or anything else, we're human beings and we're people. And one of the biggest things that brings us in our favour is the ability to look somebody in the eye and ask them what's important to you. And you can have any amount of documentation, any amount of support, but as people, as just people without any qualifications, the fact that we're people gives us a qualification to talk to people and ask them about what's important to them. And that's one of the biggest things that we all have and that the health service has in spades. And it also kind of comes about from having and developing good relationships with people. If you're the type of person that engages with people and makes eye contact with them and asks them what's important to them, you're naturally going to develop a good relationship with them, and you're going to be able to engage in conversations with people. One of the other things that people don't really think about is the nature of healthcare. Like I said, most people that we engage with or that engage with healthcare aren't there for fun. They've been jolted by a diagnosis or they've been jolted by a situation. And within that, there's an opportunity to have conversations with people. And unfortunately, that's how a lot of advanced care planning conversations come about. So there's some of the enablers and the barriers. I think probably one of the other things that's worth talking about is this whole perception of anxiety. And in terms of the healthcare, loads of people ask, how can we get over that whole aspect of anxiety with people? And I'd kind of like to flip that on its head a little bit and ask where that anxiety rests with. Is it with the people we're interacting with, or is it with us as health and social care professionals? Because the work of the Irish Hospice Foundation, we found throughout our work that people actually want to have these conversations. And Fiona said that in her presentation as well. People need support, all right, but if you give them the opportunity to have conversations, they want to do it. In 2016, we asked the people of Ireland what they wanted for their dying, death and bereavement, and over 3,000 people answered a survey, and it let us develop the People's Charter on Dying, Death and Bereavement. And I'm just going to read 2 lines from the Charter. One of them is about, the first line of the Charter is that death is talked about and not hidden away. And the second one is, I can prepare for what lies ahead. So people have told us that's what they want. So there's no real anxiety. Look, the sense of anxiety is probably more a perceived one, and it kind of probably says more about us or as health and social care professionals than it does about the people that we're interacting with. We underestimate people quite a good bit. People are quite strong and they want to have these conversations. I suppose the other piece of work around that anxiety piece is we need to give people the opportunity to have conversations. If we provide people with safe spaces to have conversations, they can open up and they can start to think about things that are really important to them. My colleague Rebecca Lloyd is a public engagement officer, and she's been running these sessions around the country called Putting Your House in Order. And there's a solicitor in the room, and in fairness, that's probably the thing that gets people into the room. But once people are in the room and they're given the space and an opportunity to talk about things that are important to them, those sessions can go on. And she would tell you, if she was here with me, she would say that people queue up to talk to her at the end, to tell them about their personal stories and tell them about what's important to them. So people really want to have the opportunity to plan ahead. They want to have the opportunity to have conversations, and we just need to give them those opportunities, and we need to create the spaces for them to do it. And we really need to stop underestimating people and stop being afraid of upsetting them, because that fear is really on our side. When people have been jolted by a diagnosis of anything, be it dementia, heart failure, COPD, cancer, any of those things, they're already upset and they're looking for somebody to give them sound information. And one of the things that you can help people to do is give them information and give them opportunities to plan ahead. Throughout all of these sessions, you've talked about the Think Ahead form. It's one thing that you could provide to people that gives them an opportunity to read things, think about things in their own time, and go and have conversations with other people in their lives as well. And it's a record for them to keep as well.
That's brilliant, Deirdre. Thank you. You covered an awful lot of really, really valuable ground there. And a lot of the things you said really resonated. And for those of you who were here with us last week, there was a very good quote which someone added in the chat, which was that professionals need to get the fear out of their eyes in talking about this. And I think that very much resonates with the point which you made. Briefly, Deirdre, because we're running we need to move on, but briefly, in terms of things which healthcare professionals can do in terms of, and healthcare workers, of starting that conversation, because starting the conversation, in a sense, from what you say, is one of the hardest things. Are there any sort of ideas you might have in terms of starting that conversation for people?
I suppose the biggest thing, and this is from my own experience as well, as working as a nurse, you need to do a little bit of soul searching yourself. So you need to be comfortable to have these conversations. It's not something that comes naturally to everyone, and it comes to people more over time, and the more you engage with it. I suppose when I started working as a nurse, it was very easy for me to shut down conversations. But there are two things I suppose I'd say to people. Learn the value, well, do some soul searching first. So be comfortable, know what you're comfortable with yourself. And then don't underestimate people. And then I suppose give people the opportunity to talk about things before there's a crisis. And then finally, be brave enough to start conversations that matter. Don't be afraid of them.
That's really helpful. And of course, when we see one patient, we see one patient. So it is, everybody will respond differently, I presume, and you would have different ways of addressing. You know, you need to maybe change tack sometimes, or is that the case, Deirdre?
Well, yeah, and like that's exactly it. We're all people. Everyone is an individual. You will, of course, come across people who won't want to have these conversations, but it's important to give the opportunity to people. So one of the most important things is to make eye contact with a person and be brave enough to say, I see you, and ask them about what's important to them, and ask them open-ended questions. Learn the value of open-ended questions. That question on its own, what is important to you, you could get a whole array of answers, and everyone would answer that very differently.
Yes, I think that's a very, very powerful point on which to leave this little bit of the discussion. We might be back to you, so don't run away. Thank you very much, Judy. That's really, really helpful. Judy, could I ask you a couple of questions? Because, of course, you are sort of particularly adept at thinking about advanced healthcare planning in the context of somebody with an intellectual disability, and who may have, and obviously not everyone with an intellectual disability will have difficulties with advanced planning, but some people may have. And would you give us an example of how you might attempt advanced healthcare planning with someone in that situation?
Okay, I'll just check at this outset. You can hear me okay? Yeah.
Very well, thank you.
Yeah, so just to give a bit of a context to intellectual disability, because that's my background, the involvement of people with an intellectual disability in decisions affecting their lives, it's really core to their freedom, their choice, and it's fundamental to their individual personal human rights. So any kind of a person-centered approach or support needs to involve people with an intellectual disability in decisions about their own lives. So advanced care planning is one way it provides an opportunity for people to have some control over what is a very important part of people's life, their end of life. And when you have a time to consider your beliefs and values, which are very important for us all when we consider our advanced planning, and to do this ahead of time before somebody's health deteriorates. So for all of us, making decisions about our future care is really complex. and these conversations are rarely easy. So affording a person with an intellectual disability the opportunity to consider what's important to them in their future care is hugely important in Ireland in particular. If we look at the context of, we have 28,000 people registered on a national intellectual disability database. So they're people who access the service. So 50% of that population are over the age of 50, or over the age of 30, sorry. So if we look at that, we can see that we have an aging population, and we have a great news story that people are living longer and living into older age, which wouldn't have happened in the past. So it really is imperative that we're considering the end of life pieces in advance. So if I look myself, and from my experience working with people with an intellectual disability, what advanced care planning, it involves a series of decisions with different levels of complexity. So it's sometimes when we look at decision making, we look at a broad, give it a broad title, to make decisions around, your capacity to manage your money, or your decision around your advanced care planning. But actually breaking down that decision within advanced care planning, there are a number of different steps or processes. So important for people with an intellectual disability that you're breaking down those processes that all culminate in an advanced care plan. So all of these decisions at separate times will need different levels of support and different levels of people's involvement. The starting point with people with an intellectual disability is the presumption of decision-making capacity. So everybody has equal capacity to make decisions, and you only question that capacity if there's a rationale or a reason for you to call that person's capacity into question. So that's your starting point, is you assume that people will have full capacity to make decisions, and then you work backwards from there. The functional approach to decision making requires that we look at people's ability to communicate in a message in whatever way or format that they can understand, that they retain the information for a short period of time, and that decision making fluctuates. And a really important consideration for people with an intellectual disability is that the intellectual disability in itself doesn't mean that people lack capacity. And it's really important in our overall understanding of advanced care planning that we understand that we come from those points of principle, because if we don't, we won't begin the planning process with people. So again, coming back to decision making, it involves examining decisions, looking at options, alternatives. Sometimes we go to other people for advice for particular decisions that we might make. So advanced planning for intellectual people, somebody with an intellectual disability, is no different. And what is also no different is that people with an intellectual disability differ greatly. Some people will have a very sound knowledge of their plans, what they want for the future. For some people who may have some use alternative methods of communication, that might be more challenging for us to understand or to know. So my starting point for looking at advanced care planning with somebody would be to the realization that it's a step process. So we need to look at the different aspects that are involved. So how does the person communicate? What's the preferred method of communication? What supports do they need to communicate? Are there any audio or visual aids that will help them communicate effectively? The right time for somebody, the right environment, the people are comfortable. These are difficult conversations to have. So people need to be comfortable around having these conversations. Also understanding the core of the person, their values, their beliefs, how they live their lives, what type of environment they lived in, and how they were supported, and what is important to them, as some of the previous speakers would have also mentioned. They would people with an intellectual disability have possibly experienced lots of losses in their life. They would have loss of staff who've moved in and out of their lives if they've lived in residential care. Older people with an intellectual disability would have experienced loss of a parent or perhaps a family member, and they certainly would have experienced the loss of friends who they may have lived with for years, or other people that they may have lived with for years. So they have lots of life experience, irrespective of their level of communication or our ability to understand the messages that they're trying to achieve. And from my own experience with people with an intellectual disability, they're very readily and really want to have these conversations, but aren't often asked. So somebody needs to initiate the conversation, perhaps, I would suggest. And a good starting point is always to sit and ask the person about their lives. So where were you born? We're all really connected to our sense of place, and where is home? Tell me about your family, your friends. Where did you live? Where did you go to school? So as you work through natural conversations with people with an intellectual disability or anybody who would suggest that your conversation can progress to the end of life. I have in the past done some research around, I was looking at person-centred services for people with an intellectual disability, but the participants only wanted to talk about death and the death of family members, and they opened the opportunity and were very willing to talk about death. So I think we fear it probably more than people do. It's also looking at the tools and supports that are there. The guidance from the Irish Hospice Foundation, they can be used as prompts for questions to support people to move a conversation along. Also looking at who's important to the person, who they communicate really well. That may not be me as a nurse or an advocate, but they may prefer to speak to strangers. Some people where communication is an ongoing issue, and where the person might need a higher level of support with decision making. There is the National Advocacy Support Service that can be accessed to support people if that's something that was required, and also, of course, the Decision Support Service. But the starting point is opening up those conversations with people around their lives, and have they been sick in the past? When they've experienced hospital before, how was that for them? How did they respond to that environment? Is there things about the hospital experience that that they would be important to them if they were at an advanced stage and needed support? Asking or understanding where the person would like to be supported. Would they like to go to hospital if they require treatment? Again, the complexity of decisions within the whole planning process. It's breaking it down again to looking at the do not resuscitate orders. And even around the COVID situation in the UK, they've had a number of cases where people with an intellectual disability had do not resuscitate orders placed upon them when for Down syndrome or for severe intellectual disability and blindness, and with no consultation with the individual themselves. So I would say that anybody with an intellectual disability, irrespective of the level of communication, communicates. We all communicate in some way. There are people who know the person extremely well, and it's to use those supports. And where there are complicated decisions around the health, it may be difficult to have those discussions. Involve the person's GP, who may have been engaged with them for a long time.
Thanks for that. Thank you very much, Judy. A lot of really, really powerful points there. And I think that the last one which you made, which was some of that stuff which happened in the UK, which was one of the things which really led us to recognise the importance of having in place a policy which made it absolutely clear that kind of decision making without the involvement of the individual is absolutely unacceptable, and that's something which is really important to reinforce. And of course, as you say, and as you've said, this is really, really important in an end of life context, but also, of course, for somebody who's going to hospital, where they may be out of their normal environment. There's a huge potential in advanced planning, even not in an end-of-life context, where moving environments and all sorts of things. And then the other point which you made, which is so valuable, which is, I think, very much reinforces what Deirdre has been saying, which is the importance of conversation and recognising each individual as an individual. There's no single person with intellectual disabilities. Everybody is complex, everybody is different, and recognising that. We've got a couple of questions which will be coming in for you, but we move on to Sean and we come back. Thank you very much, Judy. That was really, really helpful. So we're going to turn now to Sean. And Sean, we're going to give kind of a meat and potatoes question. What information do you need to put into your advanced planning? So we've had a lot of talk about relationships, building relationships, starting this conversation, but now what you actually need to say, the simple, I suppose, practical question of what you need to put into your advanced plan.
I guess it depends very much on the context, doesn't it, and where you are in life and what situation you're facing. So it is about getting your wishes and preferences, and they're going to be based, as was said, on your beliefs and values, and also on the actual clinical situation you're in. So it's very different if you're dealing with a stable chronic illness than facing something acute and potentially life-threatening. That'll obviously influence it. It'll also, and it's worth reminding people that we will have advanced healthcare directives when the Assisted Decision Making Act comes into force, and we're sticking to the line of 2021, aren't we, Mary? That'll be available. And
I think we're 2022, Sean. Am I?
2022. Whatever.
I'm afraid it's even longer.
That'll be a legally binding refusal of treatment if you drop the healthcare directive. So a very powerful document. And one could say that even if you did it now in accordance with the formalities of the Act, it would have an awful lot of moral force and arguably would also be legally valid, many people would say as well. And that doesn't need to have a doctor involved. You can do that yourself with your witnesses and draw what you want. A lot of people will find it helpful to discuss it with their doctors just to make sure that the whole document coheres and makes some sense so that people are able to respect it because it's valid and applicable to whatever situation you're facing. But even now, advanced care planning isn't a legally binding refusal, but I can think of very few reasons why people wouldn't respect it if you've gone to the trouble of expressing your own wishes and preferences. So it's to put down what you're facing and think about the situations that you might face, and depends very much on the context. It could be long, it could be short. One of the great things that the AHD legislation will allow is for you to appoint somebody as your representative, so that you don't have to think of every single situation. They can interpret your wishes on your behalf. That will be somebody you trust, and that's an enormously powerful role and very useful. And even how you could do that as part of advanced care planning, your overall preferences depending on the setting, and say, well, Mary will be able to tell you because I've spoken to her about it, and she knows my general preferences. So context specific, I would say in general, Mary.
Super. That's and again, that coheres very much with person specific and context specific, and the importance of recognizing that. Just a quick question which has come in before I go on to my next other question. Will the Decision Support Service have a role in advanced care planning?
Well, in advanced care directives, yeah. And I guess our hope was very much that there would be a register and it would be searchable, and we'd have a way of accessing it easily, because there's not much point having a plan or a directive if nobody knows about it. So it's enormously important when you have decided what your wishes are, that you communicate it effectively to those around you, and that means your family and friends. If you're attending a hospital or a clinic, make sure that they know as well what your wishes are. So the Director of the Decision Support Service will, but you don't have to worry about it right now. If you draw up your plans carefully and communicate them, then there's no need to worry about that aspect right now.
And Sean, one of the points which thanks very much, Sean, that I think is very powerful. And we hope and that there will be that register, but even short of the register, I suppose it's everybody does have to think about ensuring they communicate, whether it's advanced care plans or advanced care directives, that they find mechanisms to communicate, because without that information, it's impossible to take it into account. So communication and clear lines of communication being very, very important there. Sean, just skipping on to the question of, and Fiona talked about this, I can't remember the exact amount, but it was a relatively substantial number of people who in Fiona's work were people in the context of mental health who didn't have a trusted person and didn't have someone, and that can happen in all sorts of situations. Can they advance plan? Can they make plans for themselves? And if so, how can healthcare workers facilitate them in doing so?
Well, I think that's where the role of advocacy organisation come in. There are people who are willing to help you, and there is, in fairness, information in, say, residential care facilities about how you can access these services, and it's important that you do so, and absolutely a responsibility on healthcare professionals to facilitate you in every way possible by getting the information, by encouraging people to come in. But I would hope that in most cases, there's a good relationship also with your healthcare professionals. And it goes back to one of the questions about doing planning early rather than late. it's a failure really if you end up in the acute hospital in a crisis and I'm having the conversation and I've never met you before. And that's where we have a wonderful talk from Brendan O'Shea, which is available recording on the webinar. And the logical person to be facilitating a lot of this work is your general practitioner, who's the person you have a long-standing personal relationship with and knows you. So I think the key to successful planning in many cases is active engagement of general practice. And I'm delighted to hear from Brendan's talk and others that general practice really is stepping up to this responsibility, because they are the best placed professionals for many people, not all.
That's a really good point, which is advanced care planning means you shouldn't be doing much of this, Sean. Basically,
I do.
Shouldn't be using you, and that actually links neatly to a question, and we're coming towards the end, so we'll try to address your questions as best we can. But I've got a humdinger for you here, Sean. More information about the documentation recommendations for, I presume, under the Assisted Decision-Making Capacity Act. And of course, that's not coming into force until 2022, but just a quick zip through that. And here is a humdinger, Sean, and you're not going to get to do it in 1 minute. Where do the boundaries lie with regards to responsibility of different staff, medics, nurses, therapy staff? And I think any of you could answer that, but Sean has his mic on, so I'm going to give it to him because we're really running short on time.
I think we're getting it very wrong if you make it the responsibility of one group of people, because it is multidisciplinary, the care of an awful lot of people, and it's all about the conversation. And it may be a specific time that you're particularly close to a given nurse, and he or she is the person you want to start a conversation with. So it's everybody on board and everybody understanding the importance of doing this. And it doesn't matter if it's your physiotherapist or your nurse or your GP or whoever it is. That people are alert to somebody wanting to have that conversation, and so we shouldn't compartmentalize and say, well, actually that's for the geriatrician or that's just for the GP. It's for all of us, facilitation in all directions.
And that's I think a really good point, and you managed to answer that very well in a minute. We've one here which we're not going to be able to answer because it's a very profound question and a very profound challenge, which is when a person has clearly expressed that they do not wish to go into long-term residential care. And that one is, I think, one we would probably have to pick up again because it is a very profound challenge, and there is deprivation of liberty legislation coming. And the link between those wishes and that legislation is something that we will definitely need to be giving some time to. Any quick final thoughts on that from anyone, Sean? I know you've got very profound interest in this.
The starting position
in about 40 seconds.
Nobody should be put into, and I hate that phrase, nobody should be put into long-term care against their wishes, is the starting position. It's an enormously serious thing to deprive somebody of their liberty. And it must be in accordance with legislation which is robust and gives them every opportunity to defend themselves and to prevent such an admission. So it shouldn't be happening unless it's legal, is a basic one, and unless it's absolutely required. So very strict legislative guidelines required.
Thanks a million, Sean. Fiona, can I ask you to throw on your mic very quickly there? Question here. In mental health, there's a crisis plan in RAP that is an advanced directive. Would you have any thoughts on that? The RAP plan. Oh, and I see Fiona very efficiently has already done an answer here. Do you want to maybe say a couple of things just on that?
Yeah, the RAP plan is very, very similar to advanced care plan. And in fact, in the States, they're using it as a basis for creating a legally enforceable advanced healthcare directive. So I would encourage people, to facilitate RAP planning. It's very, very similar to advanced care planning in the mental health context. And in fact, any of us can have a RAP plan. What happens if we're, going into crisis situations? What's the signs that we're getting stressed, that maybe we need to take a step backwards? All those things like our warning signs, what people around us can do to help us. So the RAP plan is very, very similar to an advanced care plan and can form the basis for an advanced healthcare directive if it's witnessed properly when the legislation comes in.
Fantastic. Thank you very much for that, Fiona. We are coming, I think, to the end of this series of seminars. I'd like to thank very much our main speaker today, Dr. Fiona Morrissey. And Fiona has been with us for all of the other seminars, and we have really benefited, I think, from your wisdom. And I'd also really like to thank Deirdre and Judy for their really valuable, grounded contributions. And also, of course, Sean, who again has been with us for all 3 of the seminars and has made, I think, an invaluable contribution. But thank you to all our speakers, if any of them are listening, who've been with us over the course of these 3 seminars. I'm going to now hand over to Caoimhe Gleeson, who is going to give you some thoughts about where we're going to move on from this into the future.
Thank you, Mary. So just to say, the reason we're here is because of COVID, and the reason we remain is because of COVID. So for all of those that are still online, this is unprecedented to be having a webinar series in July. But that's the nature of where we are. We're still in it, and we'll remain in it for the foreseeable. So our intention is to continue this series in the autumn. So we're happy to take suggestions from yourselves, the participants that are online, because of COVID, all of our work will be online for the foreseeable as well. So we're trying to trial this. Some of the things that we've been asked to consider is to look at the whole issue of valid and informed consent. So obviously that's an area that we work in. We want to look at the voices of people who want and wish to make advanced healthcare plans. So we'll have the perspectives of individuals who have done them or who wish to do them, and that'll be a series that we'll do. Also, we've been asked as well if we can show how do you actually do this. So we're going to trial perhaps the role play or something like that, so that it kind of is action guiding for people in frontline services. Other specific tools then, what's an EPA, an enduring power of attorney, and an advanced healthcare directive? How do you use them? What's their validity? When are they? How are they appropriate? And what might they do for service? So they're the kind of early things. I'd encourage, and then some services have looked to have sector-specific sessions for their own kind of cohort or professional group. We're happy to facilitate that, and we're happy to facilitate to partner with you in terms of how that might be planned. Feel free to contact us. Just to say, our offices now, we've been rebranded. We were the ADM, the Assisted Decision Making and Consent Office. We've now rebranded as the National Office for Human Rights and Equality, which clearly in times of COVID, it's critical that we keep the agenda on human rights and the rights of people and the voices of people in these very difficult times. So I suppose just finally, I'd like to say thank you so much to all our speakers who did this at very short notice. Also to our chair, Mary Donnelly, who's actually on holidays at the moment, but still said
that isn't a bed behind me, folks.
So and to everybody that's tuned in, we're acutely aware that not everybody can tune in, and that's why we've recorded them so you can watch them in your own time when you're not on the floor. So thanks very much. I'll hand you back to Mary just to have the last word. So thanks.
Fantastic. So thank you all very much. Thank you to our speakers. Thank you to the phenomenal organisation. This takes far more organisation than it might appear. And I know Jacqueline has been extraordinary in her work in this regard, as has Marie and Orla. And also, I should also mention Ross, who has been there in the background to try to help us with all the complex technological issues, which fortunately didn't arise to the extent that we feared. So thank you all to that team which put everything together. So thank you again, all of you, very much for joining us. We hope you will continue to join us as we continue to use these webinars as a way of communicating developments, but also as a way of listening and thinking about things which are important to people, and ensuring that HSE policy in this regard reflects what's going on the ground. So thank you all very much and have a good summer. Bye-bye.
Okay, thanks.